This is a 24/7nursetutors.com lecture. 24/7 Nurse Tutors, providing unlimited tutoring.
Welcome, and thank you for joining us. Integumentary, Part 2.
The human skin has two major layers, followed by fat, fascia, and muscle. The epidermis layer of the skin consists of dry, mostly dead, and mostly insensitive skin. It is the top and outside layer. Burns to the epidermis are generally first degree and partial thickness and are not considered clinically significant. Sunburns fall into this category. The dermis lies beneath the epidermis. It is wet, has blood flow, and contains hair follicles and sweat glands. It also houses sensory nerves. Burns to the dermis are second degree and partial thickness and generally require medical attention. The subcutaneous layer lies beneath the dermis. It consists of a thin layer of fat, fascia, and muscle. Subcutaneous burns are third degree or full thickness and always require medical attention. The skin has many functions. It is the maintenance mechanism for body temperature. It is a producer of vitamin D for the body. It is a barrier. It prevents evaporative water loss, protection for microorganisms, protection from the environment, and it also has the sensations of touch, pressure, and pain. It is our identity, our cosmetic appearance. It prevents loss of body fluid, and it's an excretory organ. A burn is damage to the tissues caused by heat, chemicals, electricity, sunlight, or radiation. Burns can occur from fires. Hot liquids and steam, flammable liquids and gases are the most common causes of burns. Most burn injuries occur in the home. 75% are victims of their own actions. The populations at highest risk include pediatric and elderly citizens. Burns are categorized as first, second, or third degree, depending on how badly the skin is damaged. There are many causes of burn injuries. Some include thermal, electrical, chemical, radiation, cold injuries, and inhalation. The good news is there has been a decreased incidence in the number of burn injuries as well as hospitalizations and deaths. Yet annually in the United States, approximately 1 million people require medical attention from burn injuries. 700,000 ER visits, of which 45,000 people are hospitalized. Deaths from burn or smoke inhalation injuries account for 4,500 deaths. Most burn injuries occur in the home. 75% are victims of their own actions, and the population at highest risk, once again, pediatric and elderly citizens. Let's discuss the rule of nines. The rule of nines recognizes the fact that the adult body is fairly evenly divided by 9. 9% for the whole head, 9% for the left arm, 9% for the right arm, 18% for anterior torso, the chest and stomach, 18% for the posterior torso, the back, 18% for the left leg, and 18% for the right leg. Now, if you are observant enough to notice, that only adds up to 99%. You're smart enough to figure out where the other 1% is located. Another, perhaps easier way to think of this, 9% for the head, 9% for the left arm, 9% for the right arm, 9% for the abdomen, 9% for the anterior thorax, or the chest, 9% for the posterior thorax, the upper back, 9% for the posterior abdomen, the lower back, 9% for the anterior right leg, 9% for the anterior left leg, 9% for the posterior right leg, and 9% for the posterior left leg. First-degree burns are limited to the epidermis. This causes very painful, dry, red burns which blanch or turn white with pressure and may or may not blister mildly. They usually take 3 to 7 days to heal without scarring. The superficial skin layer over the burn may peel off in 1 or 2 days, And the most common type of first-degree burn is sunburn, as you see in the picture on your screen. And no, that's not me. Second-degree burns are very painful burns. They're sensitive to temperature change and air exposure. Typically, they blister and are moist, red, or yellowish. They appear wet. Usually they do blister and may or may not blanch. Second-degree burns will heal in 2 to 6 weeks. Scarring is usually confined to the changes in skin pigment. Third-degree burns are the most serious type of burn and involve all the layers of the skin and underlying tissue. Third-degree or subcutaneous burns appear very dry, charred, and may be yellow, gray, or black. They do not blanch and are leathery to the touch. They generally are not heavily blistered, usually cause the skin to be very waxy white to a charred black and tend to be very painless because of the nerve damage. Healing of third-degree burns is very slow, if at all, and may require skin grafting. Severe scarring usually does occur. Healing time depends on the severity of the burn. Deep second and third-degree burns, called full-thickness burns, will likely need to be treated with skin grafts, in which healthy skin is taken from another part of the body and surgically placed over the burn wound to help the area heal. Join me as we review core content in the next unit.
This is a 24/7nursetutors.com lecture. 24/7 Nurse Tutors, providing unlimited tutoring.
Hello, I'm Tim, and welcome to 24/7nursetutors.com. Welcome to the Integumentary system. Here is a chart of the characteristics of burns of different depths. I will give you a little time to look over the chart. If you need more time, please pause the video. Severe thermal injuries can result in burn shock, hypovolemic shock. This can happen due to electrolyte shifts, inflammatory response, evaporate losses. This sequence of events leads to intravascular hypovolemia and hermioconcentration that could lead to organ dysfunction, sepsis, organ failure, and even death. The most crucial aspect of early care of the burn patient is prompt initiation of volume replacement of large quantities of salt-containing fluids sufficient to maintain adequate perfusion of vital organs. Many formulas for burn resuscitation have proven clinically efficacious, and each differs in volume, sodium, and colloid content. Currently, the most widely used adult formulas are the Parkland-Baxter formula and the modified Brook formula, which delivers Ringer's lactate solution at 4 milliliters per kilogram per percent of the burn, and 2 milliliters per kilogram per percent of the burn, respectively, during the first 24 hours post-burn. I will say that again. Using the Parkland or Baxter formula and the modified Brook formula, Ringer's lactate solution at 4 milliliters per kilogram per percent of the burn and 2% per kilogram percent of the burn, respectively, during the first 24 hours post-burn. In each case, half of this volume is administered in the first 8 hours post-burn. Remember to insert a Foley catheter to monitor output. What should urine output be in an adult? At least 30 milliliters per hour. The rate is adjusted hourly to assure a urinary output of 30 milliliters per hour in adults and 1 milliliter per kilogram per hour in children. Serum albumin is replaced to keep levels above 2.5 grams per deciliter. Fluid resuscitation should be instituted as soon as possible. The volume of fluid infused depends upon the percent BSA, time passed since injury, and patient's weight. The most commonly used resuscitation formula is once again the Parkland formula. Now this is a pure crystalloid formula. It has the advantage of being easy to calculate, and the rate is titrated against urine output. This calculates the amount of fluid required in the first 24 hours. Children require maintenance fluid in addition to this. The starting point for the resuscitation is the time of injury, not the time of admission. Any fluid already given should be deducted from the calculated requirement. In the first 24 hours, Parkland's crystalloid resuscitation says 24-hour fluid replacement equals 4 times the percent BSA times the weight in kilograms. Give over half of the first 8 hours and the remainder over the next 16 hours. Following this, fluid is titrated based upon urine output and observation at intervals of 4 to 6 hours. At the end of 24 hours, colloid infusion is begun at a rate of 0.5 milliliters times the total burn surface area times body weight in kilograms. And maintenance crystalloid, usually dextrosaline, is continued at a rate of 1.5 milliliters times the burn area times body weight. The end point to aim for is urine output of 0.5 to 1.0 milliliters per kilogram per hour in adults and 1.0 to 1.5 milliliter per kilogram per hour in children. Let's calculate. What would the fluid replacement be for a client who weighed 60 kilograms and had 40% TBSA burned? Using the Parkland formula, we take 4 milliliters times the percent of body surface, which is 40%, times the weight in kilograms of the client, which is 60 kilograms. That equals 9,600. So the client will receive 9,600 milliliters of lactated ringers in the first 24 hours post-burn. That means the patient will receive 4,800 milliliters in the first 8 hours post-burn, which means the patient will receive 600 milliliters per hour for the first 8 hours. This is calculated from the time of the burn, not from the time of admission. The acute resuscitation period following burn injury generally lasts 24 to 72 hours. Fluid shifts are rapid. Serial determinations of hematocrit, serum, electrolytes, osmolality, calcium, glucose, and albumin can help direct appropriate fluid replacement. Persistent metabolic acidosis on arterial blood gases may be indicative of ongoing hypoperfusion for hypovolemia. The best single monitor of fluid replacement is urine output. Insert a Foley catheter to monitor the output. What should urine output be in an adult? Acceptable hydration is indicated by a urine output of more than 30 milliliters per hour in an adult and at least 1 ml per kilogram per hour in a child. Diuretics are generally not indicated during the acute resuscitation period. Patients with high voltage electrical burns and crash injuries have an increased risk of renal tubule obstruction from myoglobinuria and hemoglobinuria. Urine output should be maintained at 1 to 2 milliliters per kilogram per hour. If pigment can be seen in the urine and the urine alkalinized with IV sodium bicarbonate or acetazolamide with IV mannitol to aid in diuresis and to act as a free radical scavenger. The pulse rate and pulse pressure are more sensitive indicators of hemodynamic status than blood pressure. Hypotension is a late finding in burn shock. Normal sensorium and adequate peripheral capillary refill are additional clinical indicators of adequate organ perfusion. Invasive hemodynamic monitoring with central venous catheters, arterial lines, and Swan-Ganz catheters is usually not needed in the absence of a severe inhalation injury, and discretion is advised. Pulmonary artery lines especially carry an inordinate risk of sepsis, thrombophlebitis, and endocarditis in thermal injury patients. Interventions in burns include different types, cause, and then your priority. For a thermal burn, a flame, steam, or liquids, smother the flames, remove smoldering clothing and metal objects. For a chemical burn, caused by acids, strong alkalis, organic compounds, you need to brush off dry chemicals, remove clothing, and ascertain the type of chemical. For an electrical burn, which is caused by direct or alternating current or lightning, separate patient from the electrical current, smother any flames, then start CPR and obtain an EKG. For radiation burns caused by solar, X-rays, radioactive agents, remove from the radiation source. Remove clothing if contaminated using tongs or lead gloves, and then send to the Radiation Decontamination Center. Join me as we review core content in the next unit.
This is a 24/7nursetutors.com lecture. 24/7 Nurse Tutors, providing unlimited tutoring.
Hello, I'm Tim, and welcome to 24/7nursetutors.com. Welcome to the Integumentary system. The goal in treating burns is to prevent or control infection, prevent wound progression, and cover the wound as soon as possible, as well as promote function of the healing skin. Several different approaches may be used, including hydrotherapy daily to debride eschar and cleanse the wounds, topical enzymes such as collagenase, xanthan, or Accuzyme will debride more rapidly, silver-coated antimicrobial dressing, Acticoat. There could also be grafting. If skin grafting is necessary, one or more of these may be used as a temporary protection. Allograft, skin from a cadaver, synthetic skin such as BioBrain, or bioengineered skin substitute such as Transite. Let's discuss the prevention of pressure ulcers. Identify patients at risk for skin breakdown using an assessment such as the Braden scale. Inspect the patient's skin frequently for signs of increased pressure. Positioning is important. Move the patient at least every 2 hours to decrease pressure on the skin. Use a lift sheet or slide board to move the patient. Pad bony prominences, the sacrum, elbows, heels, back of head. Remove excess moisture from the skin, urine, feces, and sweat. Nutrition is important. Maintain adequate hydration, protein, and calorie intake. And use protective barriers, such as a hydrocolloid dressing, Duoderm, in high-risk areas. Exercising, stretching, and activity at least 5 to 6 hours per day is important to prevent contractures. I will say it again. Encourage your client to do at least 5 to 6 hours of activity per day. It is important to maintain normal joint motion regardless of time spent stretching every day. The client will initially be NPO. You can begin oral fluids after bowel sounds return. Do not give ice chips or free water as it can lead to electrolyte imbalance. The diet will then be high protein and high calorie. Debridement is done with forceps and curved scissors or through hydrotherapy, the application of water for treatment. Only loose eschar is removed. Blisters are left alone to serve as a protector. This is controversial. Skin grafts are performed during the acute phase. Skin grafts are used for full thickness and deep partial thickness wounds only. Remember, you are more than a conqueror and you will be successful. Join me as we review core content in the next unit.